Thank you very much. My name is Chip Routt, and I work at the University of Texas Health in Houston, Texas, at Memorial Hermann Medical Center in the Texas Medical Center. And my topic today for you is evolution and innovation, and specifically just my perspective of the recent changes that have occurred since the 1980s regarding the care of patients with pelvic ring trauma. My experience with pelvic trauma began in the 80s when I was a medical student in Galveston at the University of Texas Medical Branch. And in those days, we would see patients like this. This is one of my patients from 1990. And we would have trouble. And the reason we had trouble with managing patients like this in the late 80s and even into the 90s were just survivability. I think you can understand when the pelvis is exploded apart like this, there's issues with a lot of system injuries and also the potential for hemodynamic instability as a result of just pelvic related bleeding. Y'all may or may not know what this is. Some of you may know what this is, but this is the way people used to get transported around in the 60s and the 70s and even into the 80s. This is the the automobile that was used by usually local funeral homes that would also double as an ambulance. In my hometown, we had one similar to this. This is a pretty famous one. This is the one that transported Lee Harvey Oswald after he had been shot by Jack Ruby to the hospital. And y'all may have been familiar with that little bit of history, but there wasn't a lot with in-field resuscitation back in those days and transportation using helicopters and dedicated ambulances. That was all evolving in the 70s and 80s to where local centers were evolving and then systems were evolving. But when I was a medical student and resident, for example, when I moved to Vanderbilt in 1983, we were not a trauma center at that point. We were a trauma center, but there was no network and there was really no formal system for the patients to get to us just somewhat automatically. It's certainly evolved pretty rapidly. So as a consequence, if the patients survived, these were the types of patients that I took care of. My job was just to make sure the weights were balanced, the slings were put in the right spot, the pins in the bone weren't too infected. And then we would have patients like this for 4 to 6 weeks in complex traction, trying to put the pelvis back together somehow using all of these different pulleys and strings. And you could imagine if the patient needed a study or a test or things like that, it was incredibly complicated. Once they had some early healing, 4 to 6 weeks of healing, the patient could be transferred over to a body spica for usually another 6 weeks or so until the pelvis was thought to be healed. And again, you can imagine just 4 to 6 weeks in traction and then 4 to 6 weeks in a spica cast. This one's a little excessive because it goes to the cervical spine and head, but this wasn't abnormal for my early days of taking care of pelvic trauma. One of the things that changed things a lot were these pelvic external fixator superstructures. These became popular in the 80s. These were almost like Eiffel Towers where they would put pins into the bone, manipulate the bone around, use some traction as well, and then sometimes even combine these with spica casts. But these were popularized by Dr. Andrew Burgess in Baltimore and Dr. Dana Mears in Pittsburgh. They were big advocates for pelvic external fixator in North America. Sometimes they would even be combinations as people started to transition away from spica casts and towards external fixation. You can see here a patient, 1985, that had external fixation, fairly complicated anterior frames applied, and then the spica cast put on with a cutout for the frame, as the clinicians just had a hard time giving up the things that they were comfortable with. As a result, you can imagine after 6 weeks in traction on your back or in the spica cast, a lot of our patients had decubitus ulcerations, especially of the posterior pelvis. This is a patient that was sent to me recently from Mexico who had been about 10 days in traction, and this happened only after 10 days after injury. So it doesn't take a long time. Decubitus ulcers, so type of ulcerization is skin breakdown, can happen quickly, especially when you can imagine the skin is traumatized many times with these injuries as well. So you can see we had numerous issues with the current treatment when I was just getting started. This is what surface rendered CTs look like in the mid 80s. This took about 4 hours in the CT scan to obtain. The patient was in there forever. This is a patient that healed in a malunion, and these were not uncommon. These techniques that we use to try to hold the pelvis together weren't very effective at making reductions when the pelvis was really unstable. And so you can see the film is level, but the ischium, there's a huge sitting imbalance when the patient tries to sit. There's limb length inequality as a result of where the hips are in space. The posterior pelvis, the sacrum, hasn't healed, so it's very uncomfortable. And then the patients would often have nerve symptoms and other problems as a result of these mal and non combination issues of union that they would have. So our treatments were pretty rough on the patients, and then they didn't have great success, especially when we had significant instability. Children were thought to be like, I was always taught they were like salamanders' tails. They would just remodel, but they don't remodel when there's severe instability and severe deformity. And so you can see this is a 10-year-old female who was sent to me several years ago. She was injured when she was 6 years old and was told that she was going to remodel. And you can see she really hasn't remodeled at all. She's just healed and continued to grow with that deformity, which just gets worse and worse as the years go by. So we learned also in children that when they have deformity and instability, those also have to be reduced and stabilized. We can't just be hopeful for a result that's never going to come. The external fixator became less Eiffel Towerish, became more streamlined. The pins kind of moved from the crest down to the area just above the hips, but still the problems with the external fixator, even today. This is a patient that we were sort of forced to use an external fixator on several months ago, and you can see that even with our best efforts, we're having trouble with the pin bar clamps and the skin and the bars on the skin. We're always trying to keep the frame as close to the bone as possible for the optimal mechanical advantage. The further away the bars get from the bone, the less power they have, the less strength they have to resist deformity and displacement. This is just an example of one of my patients from the 2000s where we used, this is the late 2000s, where we used iliosacral screws posteriorly and some ramus screws anteriorly, but also a frame because she had a complete symphyseal injury. And at her 8-week anniversary in the clinic, her pins were infected. And so we removed her pins in the clinic and she started screaming, and we took an x-ray and you can see her pubis hasn't healed at all. So even despite 8 weeks in the frame and the pubis together in a pretty good reduction there, after 8 weeks, sometimes the tissues in the front of the pelvis that we would anticipate healing don't. And so this patient eventually the next day had to have a fairly significant surgery to reduce and stabilize the pubis. In Toronto in the 80s, there were numerous centers around North America and Europe as well, and across the globe that were trying to help solve these problems. One of the centers in North America was in Toronto, and there was a surgeon there named George Penal, and he started working on pelvic trauma, and he had a young protege named Marvin Tile, and they together started doing operative management. And you can see they put an external fixator on the front part of the pelvis, and these long linear devices in the back with these bolts or nuts on them that were called sacral bars. And they were doing open reductions of the posterior pelvis and then using this external fixator in the front. You could see that the patients had a laparotomy. There's a staple line, and you could just imagine if they would have just run that staple line just a little bit further down south or done a fan and steel approach and just clamped the pubis back together at the time, things might have been a whole lot better, because you can see they've trapped this pelvis they put it back together, or they've stabilized it, but they haven't really reduced it at all. So this patient, even if they heal, is going to have a significant malunion of the pelvis. So even though people were starting to get after things, there was still a pretty harsh learning curve. The other problem with the external fixator, if you wanted to operate on the back part of the pelvis, this thing was sticking out of the front. And so there were physicians like Bruce Browner, who was the chairman here in Houston in the 80s. They would put two tables together end to end, leave a space in the so the patient's frame could hang out the front, and then they could do surgery on the back of the pelvis. And certainly less than ideal, creative, but if you're the patient or the surgeon, this is not really where you want to be in life. And then our colleague Jim Kellum, who was one of Marvin Tile's proteges in Toronto, published a paper in the 80s that showed that there was about a 30 to almost 40% wound complication rate when you did posterior pelvic ORIF. And so if the reductions weren't so good and the fixations were complicated by infection 30 to 40% of the time, that's really not acceptable. I was a young resident when this came out, and my wife was a radiologist, and we were on a flight together, and I was reading Marvin Tile's book, and it was, about this thick. And she laughed at me because her books were all about that thick. And she said, what are you reading about? I said, pelvic fractures. And she said she laughed and she said, that's sure is a thin book. You almost really know a lot about it. And I, just said, well, show me your book. If you've got a book that's better on pelvic fractures, show me. And of course she didn't. So we kind of identified that there was this big knowledge gap. I think everybody, it wasn't any discovery that I had, but just where we were in time. And we realized with a 30 to 40% wound complication rate with ORIF of the posterior pelvis, there had to be a better way. So that pretty much drove my career. In the 90s, I worked in Seattle for about 24 years, from 88 to 2000 through 2012. And this was a time of a lot of change and a lot of innovation and just a lot of learning. We had a very good biomechanics lab. The group in Toronto had a very good biomechanics lab. We didn't have the internet for communication, and there was a lot of rivalry between all the different centers. And so people were driving pretty hard to try to push to figure out how to take care of pelvic fractures better. And the group in Toronto with their biomechanics lab helped a lot, and they helped me a lot just by sort of learning some foundation information, and then having a biomechanics lab at our place and a pretty significant promotion deadline that drove me to try to do it. And then I had partners that let me take care of pretty much all of these injuries. And so I grew up on a farm, and these things we tried to simplify rather than complicate. I think you can go a lot of different ways in life, but one of the ways is to try to simplify things. And we learned a lot just by working a lot and having an immersive experience. And I would encourage you, if you're trying to learn some type of trade of some sort, is just pretty much make yourself available to 24/7, 365. And that way you get a really great experience. One of the things we learned early on was not a new thing, but it was really helpful, is that David Teague, who's now the chairman in Oklahoma, he was our fellow, and he was on call one night, and he and one of the residents named Winston Warm had a really complicated patient with an injury just like this one, where you can see the left hemipelvis is completely displaced, and they just pulled on the patient's left leg and put a sheet around him and clamped it and had an x-ray result that looked like this. And this is a really good closed reduction result. They put the patient in traction on the left side. Patient was awake and alert and just felt a whole lot better. You can imagine stability and reduction give great comfort. And we knew we were onto something with this. Long about that time in the 1990, Dr. Burgess, along with Jeremy Young in Baltimore, published their classification scheme that we still use today. And this helped us a lot just from a communication standpoint and trying to understand some of the related injuries that go along with the various fracture pattern. We recognize there's a spectrum, but we had to have something to go on, and this classification system helped us a lot. Dr. Burgess is our partner here at UT Houston as well. When I first started, the 2-hole 4-5 DC plate, or the dynamic compression plate with 2 6-5 screws holding it together, was pretty much the state of art, standard of care for the pubic symphysis disruption. This is one of my patients from 1990. He was Mr. Puerto Rico a couple of years earlier, so a big fit guy. Got into a wreck in Seattle, and I used what I was taught to use, the 2-hole 4-5 narrow DC plate. And in those days, we were just learning about exposures. And so many orthopedic surgeons didn't have exposure or surgical experience with these approaches to the pelvis. So we would have a urologist sometimes expose for us, or a general surgeon or an OB-GYN doctor to get us to the pubis. And after several of these experiences, you realize that the anatomy is not that hard, and we can do this without a tour guide, because a lot of times the OB people want to go to the uterus, and the urologists want to go to the bladder, and the general surgeons want to fix the hernia. And so we had different agenda for the exposure. And so we had to learn as orthopedic surgeons how to do these approaches for ourselves. The other thing that we learned, I learned on this patient, and this was 1990, was that the 2-hole 4-5 DC plate was not going to be sufficient. It might have been fine in the 80s. And my mentor was one of the people that popularized this, and he was still my partner, and it was difficult to let him know that we had to move on, but this wasn't working out. We tried to hang on to it for a while and even add iliosacral screws when we first started doing iliosacral screws, but we still had trouble because the 2-hole plate was slipping around too much. It was too flexible, as you'd imagine it. It's a fairly unstable device, especially when you put it onto an unstable injury. So there was a lot of progress in the 90s, and most of it was due to my just clinical immersion and taking care of pretty much all of the patients for the Northwest. The devotion of my partners to support that. And then, somebody had to do the open tibias when I was doing the pelvis. And then that subspecialty or super subspecialty focus and just being available all the time really helped me to learn a lot of things that I don't think I would have learned if I would have just been taking every 5th or 6th night a call. So we learned about the wrap, and then we learned that we could challenge all of the things that we had been taught, because the patients were teaching us things that the books and the older clinicians were telling us couldn't happen. And so we were learning a lot about operating. We were learning a lot about techniques, but we were also improving a lot on clinical judgment. And I told you I was raised on a farm, and I believe that if I could, put we used to hang gates, and this to me was very similar to hanging a gate. And if you could, for example, in this patient, just open the symphysis and clamp the symphysis and reduce it, which is not a very overly difficult thing, and get it right and put the patient in some traction on the left side, a lot of times the posterior pelvic ring would line up in a really good way. And you can see the SI joint in the back looks like it just needs a compression. We also learned a lot about iliosacral screws in those days, because the advent of fluoroscopy in the operating room was just fairly fresh. And then cannulated screws were all brand new. When I first started, we didn't have cannulated screws. We just had regular cancella screws. But the cannulated screws came in the 90s. And these helped us a lot. We could put these in percutaneously, and then if we sighted them just perfectly, then they would do a good job. And so we could go from something like what we had to this in about 2.5 hours. And this was pretty phenomenal compared to 2 to 3 months in traction in a spica cast. The problem is there was really, really a lot of resistance to these techniques. And the reason is they were new, they were dangerous, they relied on doing exposures that a lot of people may or may not have had experience with. And a lot of people, anytime you have big change like this, there's a lot of, I would say, way beyond very, very slow acceptance. And most of it came from fear. Learning how to put these screws in certainly wasn't easy. And there wasn't a book on how to do it, and everything had to sort of be solved. But once you could figure it out, then it speaks for itself. So the patients were telling us really good things, and the doctors were telling us no. And so we believe the patients rather than the doctors. The other thing that we learned about was minimal displacement really did not equal stability. When I was a medical student and resident, if it was minimally displaced, it was stable. The only trouble is a lot of patients don't know that, and they have unstable injuries that look pretty underwhelming on the imaging. But when you listen to them, they'll tell you that they can't move. They're screaming in the bed. They say they have 10 out of 10 pain. They're almost hysterical. And so we know by just putting them to sleep and pushing on the ilia, we can see fairly significant instability for fractures that aren't very displaced. The other thing that happened in the 90s is we were able to work out all of these different tubes inside the bone. And these are all curved tubes to some degree, and we'll talk more about that later. But we had straight implants, and so we had to figure out a way to get straight implants into the curved bone. And these became sort of the popular pathways that we were using to put implants in to stabilize a variety of different fractures. So we could take that patient we just saw with the instability and put in a lag screw and add some screws to the sacral fracture in the back and take him from a 10 out of 10 pain with no ability to move in the bed to up on crutches and home in 2 days. And this was pretty phenomenal. The other thing you notice is a lot of imaging in the operating room that allows us to put these in safely. And then also pre and post-operative CT scans became very popular to help us to understand that what we were doing was either accurate and precise or needed to be improved. And we could go back then and look at the intraoperative fluoro, look at the post-op CT scan, and then adjust so that we were constantly accumulating knowledge and experience to make sure that we were improving our safety. There's no greater patient to support this than this patient. This is a guy who jumped off a fourth floor garage trying to kill himself. And you can see he's got injuries on the right side, injuries to his femur, injuries to his left side, his SI joint, his ilium. Everything is pretty much broken. And then by just putting him in traction and doing some percutaneous screws and targeting each site specifically and using those pathways of bone, we're able to give him reduction in stability and maybe 10 or 8 stab wounds, 3 hours in the operating room, 4 hours in the operating room. And this is a huge difference because the blood loss is minimal, the time in the OR is less, and then the stability is excellent from this. And we knew from the biomechanical studies that the stability was going to be comparable to the open techniques. The other thing we learned a lot is just imaging. It's difficult to look at films like this and not really know what's going on. But one of the things that has evolved, especially in the 90s and 2000s, was the surface renderings. And so we could take surface renderings and then ghost them onto images, the plain film, so that we could start to see what we needed to see. So the surface renderings give us a really good idea of what's happening. And then the plain films, we could really analyze harder to see how we didn't see that and what were the clues. And as you look harder and you start to really seek disease, you start to learn more and more. And then we can correlate the axial and the coronals and the sagittals to where we can really understand the pathology. And as we go through these things, you say, well, how are you going to reduce that? Does that need to be reduced from the back or the side or the front? Or, and how do I deal with the iliac artery? And how do I deal with the iliac vein? And what about the bladder injury that's got contrast all over the guts? So we ended up learning a lot and learning how to coordinate with our colleagues and tag along to bladder repairs and fix the front part of the pelvis and do different things. And so we ended up with, pelvis that you say, well, that's a lot of hardware. It is a lot of hardware, but it's also a lot of injury. And so if the patient has a lot of injury and needs a lot of hardware, and I'll just tell you that it could be a whole lot more, that's still not a lot of hardware. And you say, well, why can't we just do it percutaneously? We can do percutaneous stuff. You can see the left-sided posterior pelvis is percutaneous, but sometimes things like this iliac fracture with the sacroiliac dislocation, that has to be open reduced. And you can still treat it with percutaneous fixation. You don't have to, but you've exposed it and you're looking at it. And so a lot of times when you see plates applied, it's just because the surgeon is looking at it and clamping it and just applying the implant. So when you see closed techniques only, it hasn't been open. So for example, the sacral fracture on this patient wasn't open. This patient had similar injuries to our last patient. They're a little different, but she was thought to be stable. And you can see that her clinician left her without surgery, and she has non-unions and malunions. And that's just terrible. And this happened in the mid 2000s. This was a patient that was referred to me in the mid 2000s, and she was pretty desperate for something to be done. And what would have been a whole lot easier if her clinician would have sent her to us, 2 years earlier when she was broken, so that we could, I mean, she's got injuries that are very similar to these, and we could have done something similar to this. So we've made a lot of progress, but we still have a lot of work to do in the education field of making, people aware of what's available to the patients. Just speaking of that, a lot of innovation has been device focused, and that's understandable because surgeons like things that are new, and they like shiny new things. And that's great as long as the new thing is a good thing. And so what happens is the surgeons sort of leave behind the clinical acumen for making a more accurate diagnosis, or learning the imaging that we just talked about, or having a excessive exposure to where you have improved judgment, or working with people that can help you learn or accelerate your clinical judgment, or learning the details of the exposures and where the retraction should be and how to optimize exposures, and then how to use clamps. I think if you showed this x-ray to 100 surgeons, most of them would miss that the ALA on both sides are up at the level of L5. They would have just, if I hadn't labeled that as L5, they would have probably just assumed, their brain would have told them that was the upper sacrum, because this is a pretty terrible injury. And then if you ask them to plan this, they would go straight to what device they would use. And I would say 90% of surgeons would just go straight to, oh, I need blank for that. None would say what kind of approach, how to position the patient. Can I see more imaging? Where to put the clamps? How the clamps could be out of the way? Where the approach would be optimal? And then finally get to, once they had the reduction, what the imaging was, and then how to put a device in to stabilize it. So we're a little bent. And I think it's easy for me to say because I've been a part of this evolution. If I had missed the evolution, I think I might be very device focused also. But I came from an era where we didn't have a bunch of devices to, help. And so we tried to do what we could with what we had. So I'll just say that, the little details of exposures and clamps, these all make a huge difference. And it's not just the implant. You can see what happens when we unleash the beast of these new techniques. This is a very good orthopedic surgeon, but maybe they don't understand this aspect of orthopedic surgery as well as they should have. And, this patient, who was actually the nurse of the doctor with some sacroiliac arthritis, she woke up after surgery with nerve roots that aren't working. And so we have to be able to know exactly what we're doing. We need to know what we're doing and know it well before we start just trying to do things that we don't know how to do, because it's dangerous work, and it has a permanent impact on people if we don't do it properly or precisely. The other thing is it hasn't just been confined to orthopedic surgeons. This innovation of devices leaked out into other realms, and some of the stuff has worked. So like you see, this patient is an osteoporotic patient with lumbar fractures, and you can see they've injected some methacrylate to treat one of the lumbar fractures, and that's been a good technique. The other thing they've done is they've applied some devices to attempt to consolidate or stabilize an arthritic SI joint. But the trouble is the surgeon didn't really understand what to do and was just doing stuff. And so you can see this is a device that's not even in the bone. And so I don't think this surgeon got up in the morning and said, let's see what I can screw up today. But there has to be some pause when our abilities and our intent are mismatched. And this is where I think the educational aspect of it comes in. And that can be from peers, or from reading, or from courses, or from reps, or whoever. But someone has to know what to do in order to teach the person how to do it properly. And then they have to understand it. We also see new devices that are just being pushed onto things that are inappropriate. This is a recent case that was used to treat a U-shaped sacral fracture. And this patient's fracture is outlined in black. And they put in these new devices, but the 4 of the devices don't even engage the area of instability, and 2 of them do to a degree, but not a very significant degree. So it's important for the clinicians to understand what they're taking care of. I once had a double board certified orthopedic neurosurgery surgeon tell me a quote that at the front desk in a rage. He screamed at me and he said, "Look, just because I don't understand the injury doesn't mean I'm not qualified to operate on it." And I'll never forget that. I actually made him repeat it since I wanted to write it down. But we don't want to get into that point where we think that just because we've done some type of training or some type of education that we're actually competent in everything. There's so many things in orthopedic surgery that I don't know how to do, and it's important to get help when we get to that point. The other thing is the spine injectionists have it's a good operation for the collapsed vertebra in the right patient, but they've wandered on down into the pelvis, and this is just sort of a knowledge thing. And sometimes things are intuitive or deductive. They say, well, if it was good up there, sort of good for the goose, good for the gander. But if it's good for the goose, it might be not be so good for the duck. And just because they're similar, duck and a goose are two different things, and pelvis and the spine are two different things. And so we can't just slather on some bone glue and hope that it's going to magically consolidate an insufficiency fracture. So this doesn't really provide fracture stability. It doesn't promote union. And then what happens is these chunks of concrete block us from doing the surgeries that we like to do. So we do have some trouble with the injectionist wandering down into the pelvis. And the cool thing about that is they don't even have a clinic for follow-up of the procedure. So that's another really problem area. Newer devices have come along that have enamored physicians because they are sold as making the clinician's life easier, and there are some fads. They make things speedier. Sometimes they carry a higher billing code, and so sometimes surgeons are sort of lured into doing things that they may or may not know how to do for a variety of reasons. And this surgeon, I spoke to him after the surgery, and he had no idea that his iliosacral screws were intruded on both sides, and he had no idea that this screw wasn't even in the ilium. No idea. And he'd been working for 8 years, and he does about 30 or 40 of these a year. And I tried to talk to him about it, and doesn't really have any intent to try to do any change. He's very comfortable with what his current practice. But this is not a great way to go through, and just you have some experience. People just know what they know, and they don't know what they don't know. And sometimes you can't see what you don't look for. And so the beauty of the postoperative CT scan or the postoperative imaging allows us to identify the problems that we have. And then those can be clinical or radiographic or technical, whatever it is. And then we can adjust and adapt. But if we don't ever want to look, or we don't really care, it's hard to make progress. One of the easiest things is just listen to the patient. See if he would have just asked his patient. I asked this patient how she felt about this thing, and she said she thought her doctor. Hey, I said, who did this to you? And she said, I don't remember his name, but he must have hated me. And I can understand that. So sometimes new doesn't always mean better. And you can see here, this is a surgeon that went to one of our courses. And some of the screws are in the bone, some of the screws go through the fracture, some of the screws are not in the bone. And just going to a course or having some level of education or having some certification is really not validation of your technical abilities. So I do have some good news with all that bad news. I have some good news. There are some things that have been really transformative, and they're sort of in the urgent, emergent, resuscitative mode, and also in the intraoperative imaging. Some of it we sort of talked to you about, but we've learned a lot, and we're still learning a lot. But we can take fairly terrible injuries like this one, pull on the legs a little bit, put a sheet around them, and then cut some holes in the sheet. Put in the guide pins for just regular iliosacral screws, put in the lag screw, compress the SI joint. We notice that the other side is gapping a little bit, so we can put a screw over there too. And then in the operating room, we have these new devices that allow us to have, it's a fluoroscopy device, but it also has some technology that allow us to get almost CT quality imaging to look and see what the reductions look like and see where our screws are. So real time in the operating room, we can assess in about 6 to 8 minutes where these screws are and how these reductions are. And then we can compare those to CT scans after surgery and see they're not quite as good as a CT scan, but they're for what you have in the operating room. They are excellent for helping us assess to make sure we know what we're doing at that time. The other good news is there are devices that really work, and one of those is the CurvaFix device, and it's another transformative device that can be used. I think people understand this for unstable pelvis fractures, and allows you to get fixation, stable fixation of the pathways when the straight implants won't work. And you can see straight implant works posteriorly for the sacral fractures, but doesn't work for the ramus fracture. But we can put the CurvaFix in to accommodate this curve, and you can see on these these axial and coronal images how the device fits it. We can also use it in insufficiency or elder fractures, where we have patients like this who's 83-year-old guy who took a fall, and you can't hardly even see his bone. But when you look at his surface renderings, you can see his arthritis, you can see his upper sacral fracture. We can get renderings to see the different areas of injury, and then the axial CT scan can show us where the fractures are that are causing him problem, but also the bone pathways. And again, this wouldn't be amenable to a transsacral screw, which would be something we'd like. So we can use the CurvaFix device for this to accommodate the osseous fixation curve pathway. And by using the guide pin and then negotiating the pathway, getting the depth or the length of the device, reaming this area, exchanging this for a guide pin, and then inserting the device that accommodates the osseous fixation pathway in a curved way, and then locking it in place, then we can have a single device that can manage this patient's injury through a stab wound. And you can see on the axial images the curved portion and how the device fits these oblique pathways, so that rather than having short screws coming from both sides, he has a longer, larger device coming from a single side that accommodates the pathway. So I'll just stop with that good news and tell you that from at least from 83 is when I started to 2015, there's been incredible progress with this. And I think it's incredible progress in every way, from diagnosis to resuscitation to on-site resuscitation to paramedic education, centralization of systems, transporting and getting the patients to the places where they need to be, and then getting away from some of these older techniques that we had, helping clinicians understand that identifying instability just because it's not very displaced does not mean that it's stable. And then using the imaging, the CT scan, the CT scanning has gotten so fast and so quick. You can have, I get a chest CT every 4 months to follow my tumor, and they do a chest CT with contrast, and they put an IV in, I lay down, they scan me in about 1 minute, and then they inject the contrast. They scan me in about a minute and a half, and I'm done. It's about a 10-minute total process in order to get a really high quality CT scan these days. The other thing is the intraoperative imaging has been refined completely, like we talked about, and that gives us real-time information so that we can either see that we've got the reduction that we thought we had, or we have the implant where we wanted the implant to be, and that we can correlate our intraoperative imaging with the intraoperative sophisticated imaging. Still a ton of work to do with education. Again, people just don't know what they don't know sometimes. Sometimes they kind of know what they think they know, and we have to do a better job of putting a big blanket of education on people that are doing the work, because more and more people are doing the work, so they're getting less and less experience. The number of patients are going up, but not to a point where the number of doctors doing it. Still, innovations need to happen. CurvaFix, a good example of that. The intraoperative imaging, good examples of that, but plenty to do. So I appreciate y'all inviting me to speak to you. I hope this helps. This is just one person's perspective of what happened, but I was pretty deep into it from, I would say, around 1988 until just yesterday. I was still putting in screws just yesterday. So I appreciate y'all having me, and thank you very much.